Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Lourenco Peixoto from Rio de Janeiro, Brazil. Dr. Peixoto works in the National Institute of Orthopedic Surgery since 2007, leading the hip surgery area since 2018. He specialized in hip surgery with special interest in sports-related injuries. In 2012, he did a one-year fellowship at the Steadman Philippon Research Institute, mentored by Dr. Mark Philippon in the United States. His research interests are biomechanical aspects related to hip preservation, hip arthroscopy for skiffy patients, pubalgia treatment, and minimally invasive total hip arthroplasty by means of a direct anterior approach. In 2015, he was elected president of the Hip Surgery Society of Rio de Janeiro for a two-year period. In 2018, he was chosen as the chief of the hip surgery area of the National Institute of Orthopedic Surgery at Rio de Janeiro, Brazil. So today, it's my great honor to introduce you to Dr. Lourenco Peixoto from Rio. Over to you, Lourenco.
Hello, everybody. It's a big pleasure to be part of this project. Thanks for the invitation. Today, we are talking about pubalgia. I think that pubalgia is very, very interesting theme. And that's interesting to observe that in literature out there, the papers out there, there is a big mess in terms of definition of what is pubalgia. For some, it's pubalgia, core muscle injuries, adductor lesions, and etc. So there is a big confusion out there in terms of definition what pubalgia is. So for some, it's a groin injury. For some, it's a rectus abdominis tear. For some, it's a joint problem of the symphysis. For some, it's a adductor longus enthesopathy. In reality, I believe pubalgia includes all of these pathologies, kinds of pathologies. I started studying pubalgia during my stay in Vail, Colorado with Dr. Philippon. He does lots of FAI patients. And I started observing that most part of these patients had some kinds of injuries in their symphysis, pubis. So I asked Dr. Philippon, where should I go to understand a little bit more about these pathologies? And he referred me Dr. Mushavek in Munich, Germany. So I came over there to operate with her and talk a little bit more and to try to understand a little bit more about pubalgia. Then after that, we came to St. Louis, Missouri with Dr. Michael Brand. He's a very nice guy, general surgeon specialized in pubalgia treatment. And Dr. William Myers from US as well. He came to Brazil and had a great time together, talking a lot about this very difficult issue. And after all of this, we started working more and more with this pathology. What we know for sure is that this pathology is very frequent between professional athletes. 0.5 to 6.2% of these patients will have some kind of growing pain during their season. In Brazil, we have lots of soccer players. Look at these, 58% of professional soccer players will have some kind of growing pain during their careers. Xtrend published as well, 5 to 23% of soccer players will have growing pain during their careers, and it represents 8% of all lesions during one season. So there are different kinds of pubalgias, and that's what I like to talk about. You have to think differently depending on the history, the physical findings, and the images. So we have different pathologies between under the terminology pubalgia. So we have to discriminate between these different pathologies to offer the patients the correct physiotherapeutic treatment and surgical treatment as well. So I'm talking a little bit more about sports hernia. That's classically these patients have growing pains. Sometimes it's irradiated to the perineal area and the medial part of the thigh, because there is some kind of lesion of transverse fascia, and we have the genital branch of genitofemoral nerves who crosses this area under the spermatic cord. So frequently we have some kind of injury to this nerve, and these patients have pain in the perineal area and the thigh as well. Classically, these patients have the growing pain when you palpate this area, and it's easy to see this lesion, the sports hernia lesion, when you ask the patients to do a Valsalva maneuver with the ultrasound, a dynamic exam. We are doing dynamic exams with MRI as well today, just for us to be sure what we are dealing with. Sometimes when we do it in the office, it's a kind of, is an examiner dependent. When you do it with MRI, we have the static image and you have some kind of support, a little bit more data to show the patient before you plan to go on a kind of repair of this lesion. So that's a good example of Mushavec technique repair. And that's a dynamic ultrasound of that patient with sport hernia lesion. So that's very frequent in Brazil, mainly between, I would say 35, 40 years old patients. They usually are do not respond to physical therapy, this kind of lesions. That's my experience, at least. In this kind of lesion, this kind of pubalgia, it's the most frequent lesion in the office, because it doesn't respond to physical therapy usually. There are some publications out there. That's a paper from Dr. Mushavec. She does a minimally repair of these lesions. She shows 98% of good results between professional athletes with 4 weeks after surgery returning to sports. That's a William Myers paper with more than 8,000 patients operated over 2 decades with a posterior wall repair in adductor tenotomy with 95% success with surgical treatment. So the other kind of pubalgia, and that's the most frequent everywhere, not in the office. In average, that's the most frequent lesion. That's the poneurotic adductor longus tear. So there are some kinds of these lesions: adductor longus avulsion, myotendinous junction tears, and the most frequent adductor longus tear isolated. That's the classic lesion. That's Neymar playing against Cameroons. He is a right foot shooter. When he shoots and when he hits the ball, he feels the pain and he puts his hand over his thigh. So that's the classical adductor lesion mechanism.
You're not going to like this one.
That's another lesion. You see when he contracts his adductor, he feels at the same moment he feels pain, and he says he felt something pop. So that's the history data you have to collect during examination of these patients. And these are the classical images of the MRI. You see the prepubic aponeurosis lesion and a secondary cleft sign in the frontal view in the MRI. That's because that's a unique structure, the rectus abdominis tendon, the prepubic aponeurosis, and the adductor longus. So when you pull the adductor longus, sometimes it causes a tear of the prepubic aponeurosis. That's the classic lesion. So these lesions go very well with physical therapy. Usually they are not surgical, there is no surgical indication for these kind of lesions. Sometimes corticoid shots, that's enough to deal with these pathologies, but usually physical therapy is enough to deal with these lesions. The other subtype of pubalgia lesions is the articular pathology. That's kind of lesion where the patients feel pain over the joint. I've seen lots of these patients after pregnancy. They start usually in Brazil, for example. I think it's lots of parts of the world, people are thinking about getting healthy, doing lots of exercises. So I've seen lots of post-pregnancy patients who start running a lot or doing CrossFit or HIIT, high intensive training. They start feeling pubic pain with no previous history. We've seen these lesions in hyperlax patients as well. So the diagnosis is not difficult. Usually they respond to local anesthetic injection. That's a very interesting case of a nurse from my hospital. She had a peritrochanteric pain at this time. She had this x-ray. After a few years, she got pregnant and she delivered. And then after that, she started running. And that's the x-ray after initiating his pubic pain. So that's the CT scan and MRI of her pubis. She had a classical finding of pubic instability. That's another patient, the same history. After pregnancy, start running and doing lots of exercises. That's a flamingo view showing instability of her pubis. A colleague of mine did this repair, trying to fix the instability. She got better, but a few months later, she broke one of her screws because he did not consolidated the joint. So she started feeling pain again. That's another patient with signs of hip symphysis instability. That's the MRI of this patient. Sometimes you see it associated with FAI as well. Another common kind of pubalgia is overload lesions with bone edema. These are the easiest pubalgias. It's just keeping the patient out of the overload or diminishing the training frequency, and usually these patients get better. And I think the most challenging type of pubalgia is the pubalgia associated with FAI. That's a very interesting biomechanical analysis of a professional soccer player with left hip FAI, pre and post-op. You see how FAI limits the range of motion, and that's easy to imagine how this limited range of motion may overload the symphysis. That's a patient of mine. He's a professional basketball player. He had pubalgia, not responding to physical therapy for months, maybe 1 year and a few months. Look at his biomechanics. He has a huge FAI. So probably that's why his symphysis never get better. So there are some biomechanical studies with specimens, with cadavers, showing that FAI overloads the symphysis. There are lots of examples. I do lots of FAIs patients, hypertrophy, and I see it very frequently. I'm going to show you a few examples of my patients. You can see it's a classic FAI can lesion with overload and symphysis. Another FAI patient with signs in the pubis as well. That's a right hip, mainly right hip FAI. It's bilateral, but the can is bigger in the right hip. You see there is a labrum tear in the MRI and pre-pubic aponeurose lesions as well. That's it's not just for cane lesions. That's an example of a pincer lesion, bilateral pincer lesion with a pre-pub aponeurose lesion as well. That's a very interesting patient. That's a engineer. He's 22 years old. He had a pubalgia for 2 years, no results at all. And he had this bone edema in his pubis. And he had this image of FAI in his right hip, but he did not have pain, even in the provocative maneuvers. And I told him I would not treat his hip until he had pain in this joint. And a few months after, he started complaining of pain in his right hip. So I gave him, okay, let's treat your hip. I did not do anything in his pubis at all. So I did a hip scope, I treated his cane lesion, and that's his MRI 4 months after surgery. That's pre and that's the post observation. The edema was gone. He had 2 years pain and it's solved. So when you treat the pubalgia, you must think about the hip, because sometimes that the hip is the problem. So that's a video of his hip. It's not running. I'm sorry, but you can see there's a labrum tear. He had a chondral lesion, the acetabular area. So we did the repair and the osteochondroplasty. And it's been like 4 or 5 years since we did this surgery, and he's still doing very well. So there are lots of papers out there pointing to the relationship between these two pathologies. These are NFL players study where they observed association between rectus abdominis, adductor longus, and FAI, what they call the sports hip triad. That's a study done by Brian Kelly's group in New York. Few studies associating diminished range of motion with groin pain, hip pain during season. And that's interesting because some groups treat pubalgia with adductor tenotomies. When you have just adductor tenotomy pathology, in that group show these results, good results, 75% of satisfied athletes with just tenotomy of the adductor longus. But what is interesting is that between the failures, and they showed 8 patients, 5 of them presented positive provocative tests for FAI. And the authors concluded that they would have treated the hip first or in conjunction with adductor lesions. So if you have a adductor lesion, look at the hip as well. So that's another paper of a group who treated sports hernia, exclusively sports hernia patients between 1999 and 2011. And they observed between the failures, 63% of their patients have clinical signs of FAI. When you do the opposite, when you come from the FAI patient, that's an interesting paper from Switzerland. They observed 83 symptomatic hips with radiological signs of FAI. So they started with FAI diagnosis, and they started looking for signs of pubalgia. In the dynamic ultrasonography, they observed 41% of signs of inguinal herniation or sports hernia, and 23% are adductor tenotomy. So there is a strong relationship between these two pathologies for sure. In our experience, we did operation in 48 cases, 32 months follow-up. All of these patients have interference with their sportive performance. Just for me to show you a little bit of our reality in Brazil, 66% of our patients were bilateral lesions, and most part of them, 86%, were males, and they were in 62% recreational athletes. Most part of them played soccer. The second part of them were runners, usually 35 to 45 years old runners. Most part of them of patients we operated on were sport hernias. So we did the Mushavec repair in 96% of these patients, associated in 62% with adductor tenotomy. 91% of our patients return to sports with no limitations, and the pain improved very well. When we analyze the epidemiology of our patients, we have seen already in our offices 245 patients. And mainly, they are males, 25 to 40 years old, recreational athletes. Usually, they train 4 or more times a week, usually soccer or runners. We showed our epidemiological results in ASCA 2018. So a little bit more of our data. So we are very excited about treating these patients. The message here is I'm a hip surgeon, and I see lots of association between these two pathologies. So the message here is look for the hip as well. Frequently, the hip is involved. And it's also important to understand that sports hernia is different from adductor tenotomy. That's different from symphysis instability. So you have to understand the subtype of pathology, the subtype of pubalgia, to be able to treat not only surgically, but also conservatively. So thank you guys very much.
Thank you, Lourenco, for that fantastic presentation. Just a few questions. How do you really treat symphysis instability? For example, you showed that radiology with a lot of lighting lesions in the symphysis pubis. So how do you approach a patient with those lysis in the symphysis pubis?
It depends on if you have, sometimes you have lysis in the images associated in a male, in a man. He's not hyperlax. And he has, for example, huge cane lesion in his hip. So most part of the time, in this case, I do the hip repair, and I do just osteochondroplasty of the symphysis. I clean it up with a fan steel approach. I just clean it up and let it go. I keep the inferior ligament. I don't touch the inferior ligament and the posterior ligament. These are the most strong ligaments in the field, in the symphysis. You should not touch it. So you don't touch it, it's stable. It's still stable. So I just go inside and clean it up. When I have an instability case like this, I showed you, most part of the time, I try not to operate on these patients, but the only treatment I think to these patients is arthrodesis. I don't think about anything else. When you have an instability case, which not go well with physical therapy injections, I do injections first, of course, before thinking about surgery. But when we have a big lysis, like I showed in the nurse from my hospital, and it doesn't get better anyway, I would propose the arthrodesis with plates, like I showed you, with some bone graft, for sure.
Okay. Do you believe in dynamic instability? For example, do you take dynamic views, like single stance, patient standing on one leg, and look for dynamic instability of the symphysis pubis?
I'm sorry, I beg your pardon. Can you repeat, please?
Do you take dynamic views of the symphysis pubis? For example, if you can ask the patient stand on one leg and alternate and see the degree of displacement of the symphysis pubis.
I believe in physical exam, much more in these flamingo views. I did not ask for these images. This patient came with it. I don't believe a lot. I don't give a very, I know that there are some papers out there who says that 2 millimeters migration when you are standing in the right and the left, when you have more than 2 or 3 millimeters difference, that's a positive test. But I believe a physical exam is more important than this. So in reality, I don't ask for flamingo views in my practice. I do the physical exam. I always look for signs of hyperlaxity, Baton signs. I believe in Baton signs when you ask patients to stand their arms, and when you have more than 5 points, you consider this patient lax. And the history as well after pregnancy, so I try to do when it's after pregnancy, I try to wait a little bit because you have hormones and other stuff going on after delivering, but sometimes it doesn't just don't get better.
And what about the adductor tendon tears? For example, if you have a complete tear of the adductors, how do you go about it generally?
I'm sorry.
If see, one of the categories that you mentioned is an adductor tear, right? The tear of the adductor muscles.
Yep.
So once you've documented an adductor tendon tear, how do you go about it? Is it if it's a partial tear or a complete tear? How do you go about it?
I'm sorry, I didn't get it. Can you repeat, please?
Yeah, no issues. Maybe the language is a concern. If you have an
I think that's the connection a little bit. It's failing a little bit.
Okay, no issues. If it is an adductor tendon tear,
Adductor pain?
Yeah, adductor tendon tear. The tear of the adductor tendon. Did you get me?
Got you. I got you.
Okay, so how do you approach the adductor tear?
Yeah, usually what I do is just anatomy of the adductor lesion. That's a simple approach, minimally invasive technique, and that's enough for most part of these patients. You have to wonder then that sometimes the images on the MRI takes time to get better. So sometimes they are anxious. They ask for a new MRI to see if the lesion healed. And sometimes it takes time for it to get better. So that's you have to have a conversation before for the patient to understand that takes time. But most part of the time, I think the adductor longus tenotomy, it's enough. That's what papers out there show us. I was thinking about getting inside the prepubic aponeurosis by means of a funny steel approach to try to fix it with anchors and etc. I think that's a good idea. I don't know of other parts of the body where people do tenotomies. I think it is an old-fashioned treatment, but that's what we see out there in most part of papers. But I'm trying to think in a way to approach this lesion not doing tenotomy. I think that's we should do it better. I think we should do it better. Maybe endoscopically. I don't know. Maybe should fix it. No, that's what I want to do. That's my goal for the next few years, to try to fix these lesions and see what happens.
Okay, Lourenco. I think that's all the questions that we have, Lourenco. Thank you for the fantastic lecture. A lot of new learning and insight, and it is our great honor to have you on board. Thank you very much.
I really appreciate your invitation. Greetings from Brazil. We love people from India, and hope we see each other very soon.